Good afternoon, class. My name is Akudo Chioma. Welcome to my DMP Scholarly Project presentation. My topic is improving access to naloxone in homeless prevention program. I would like to acknowledge each and every member of my committee, especially Dr. Carol Berger, for, for their support throughout this project. This is a brief history of opioid epidemics in United States, and this is according to a recent study by the Haslog Gurley et al. 2022. This graph showed phases of opioid epidemic by different sources of opioid death. And in early 2000, it shows that the leading cause of death was from opioid death was from the prescription, followed by heroin in the 2011-13. And in the recent years, according to this graph, you can see the significant increase from in the last 5 years, showing leading cause of death from the synthetic opioids, which includes the fentanyl. There is no doubt that the opioid use disorder and overdose is a major growing health problem. Introduction to the and background of this topic. I currently work as a psychiatric mental health nurse practitioner for a VA homeless prevention program, and I have seen veterans struggles with substance use. It is reported that 1 out of 10 veterans are either using opioids legally or illicitly. Opioid use disorder among homeless veterans has steadily increased in the last few years and solely due to the influx of fentanyl. Drug overdose is among the most common causes of death in homeless population. Studies have shown that homeless veterans with opioid use disorder are twice as risk for overdose compared to their counterparts. And despite this high rates of opioid related death among this population, there is no intervention targeting homeless veterans residing at VA contracted housing. There are several theories on the barriers to accessing care and proper treatment as the leading factor. Also, opioid overdose is preventable with proper education about opioids and the use of naloxone, which will be referred as OEND, opioid education and naloxone distribution, throughout this presentation. I have the evidence that suggests that increasing access to this life savings medication and this training decreases opioid related death among population that are at risk for overdose. This leads to my research question. Among veterans, homeless veterans residing in VA contracted facilities, does the implementation of opioid education and naloxone distribution program as compared to no program increase the screening for opioid use disorder with subsequent education and naloxone distribution with appropriate when appropriate in this population? Several literature search was conducted, and after filtering for relevance and applying inclusion, I was able to determine the themes that provided foundation for this research question. The major themes are homelessness, opioid use disorder and treatment, overdose, and harm reduction, which is the OEND. This first study here by Ihanacho and Associates showed a bi-directional relationship with Opioid and Homelessness. It is a National Veterans Health Administration study. It states that out of 99,394 veterans with opioid use disorder, about 34,000 were homeless. Also, in contrast, out of 5.4 million veterans with opioid use disorder, without opioid use disorder, 157 of them are homeless, which shows a risk ratio of roughly 29% homeless veterans with opioid use disorder compared to their counterparts. In similar studies, it shows low percentage of homeless veterans receiving opioid agonist and also opioid anti-agonist as despite the increased rate of the opioid use disorder. It is noted that homeless veterans are high utilizers of emergency room and also prone to having other psychiatric disorder compared to other veterans. These are more evidence on the prevalence of opioid use disorder and overdose, including the unintentional overdose among homeless veterans. Numerous studies identify risk factors associated with this population, opioid related injury and opioid and overdose, to include lack of access to mental health treatment, increased access to illicit drugs, stigma, and lack of overdose prevention program, to mention a few. Naloxone or Narcan is opioid antagonist that reverses the effect of opioid in matter of seconds. However, it has been demonstrated that accessing this medication is difficult for homeless population. Opioid education and naloxone distribution is a harm reduction intervention proven to reduce opioid morbidity and mortality in individuals at risk for opioid overdose. In these studies, it shows that the effectiveness of OEND training and one study by the Testrop et al. Shows that out there, shows that those that participated on the OEND training was able to intervene in 45 opioid overdose with no fatalities. While others on the other studies stressed on the importance of expanding access to OEND in communal settings, which include the transitional housing, friends, among families, peers that are likely to witness overdose as the important factor in improving overdose in improving knowledge about opioid overdose. Sorry. Furthermore, a study by Reef and Associates, led by two MPs and a pharmacist, targeting homeless veterans in transitional housing, demonstrated increased access to OEND by 44%, and many veterans in that study used the naloxone at at least once to save their peers. Increasing access to OEND in veterans residing in VA contracted housing is relevant in reducing harm related to opioid overdose. Also, addressing the barriers indicated above will also improve care and health outcome among homeless veterans population. This is the study's aim. We aim to increase opioid use disorder screening and implement the OEND program in homeless veterans residing in VA contracted housing who suffer from opioid use disorder. This I use the theoretical framework of Cotter's 8 step change model. And these are the list. I'll go through each and every one of them. In a sense of urgency, I created an awareness of opioid overdose crisis and the need to increase naloxone access in homeless veterans population. Discussing the risk in step two, I formed team members which are the homeless prevention program staff members, the supervisors. Also, for the step three, step three involves defining the project goal, the process to achieve the goal, which is increasing opioid use disorder screening and also the OEND training. Step four, discuss the importance of the change using both formal and informal training. Also, the use of brochures and flyers were provided to those attended the training. In step five, we identified and removed any potential barriers by answering any possible question that team members may have concerning the intervention or the change process. It creates sense of belongings to team members. In step six, we celebrated early wins. We noticed an increase in naloxone prescription within 2 weeks of implementation. Also, for the improving change by monitoring team members to ensure that they stay on task and focus on the goal. Finally, to ensure that the OUD screening and also the OEND training is rooted in the organization culture, I was able to modify our psychosocial assessment template to include the new change, focus on the wins, share outcomes, and provide ample opportunity for staff to develop and master the skills. Methodology for this research was I used the retrospective chart review, which looked into past record. The the review were done 8 weeks prior and 8 weeks post intervention for comparison result. And these are the numbers. These are my intervention. Provide education to clinicians on OUD screening and also providing education on overdose prevention, which involve recognition of the overdose symptoms and opioid overdose rescue and ensuing distribution of the naloxone kit. The settings used for this study were four VA transitional housing facilities, and there were inclusion criteria since participants were not engaged. Samples included 75 pre and 75 post intervention group. Ages were 21 to 75, both and male, and subjects were seen between October 25th, 2022 to February 14, 2023. To answer the research question, 75 pre and 75 post intervention groups were reviewed and deemed sufficient for this study. I also consulted with Maryville University statistician in determining the sample size. Sample were chosen based on veterans' enrollment in program by using homeless operation management and evaluation system and also HODVASH log, which is the Housing and Urban Development VA supportive housing log, and the list of patients who participated on the OEND training. Data collection sheets were used to gather information within this time frame and from both pre and post intervention. Variables were if veterans screened for opioid use disorder, if medlist contains naloxone, if or whether OEND was provided and if naloxone was prescribed. So the responses were recorded on the data sheet using the yes or no responses. These are my analysis. Subjects were sampled in two proportion group and a two pair Z score analysis was used to determine the significance, and the result shows a statistical increase in pre and post intervention as stated by this graph below. And the table here shows the fraction and the percentage and also the graph. Limitation for this, the major limitation is the limited time. It prevents the opportunity for follow up and to identify the long term outcome of this study. There were no provisions for a naloxone refill and also those veterans that refused the naloxone. I also think that not having OEND as a standard policy for population that are at increased risk for opioid overdose is also a limitation. The outcome of the study and also the clinical implications. This is a quantitative comparative research design using a pre and post intervention to data to determine if there is an increase in opioid use disorder screening and OEND. The goal of these studies was achieved. Clinicians in homeless prevention programs were trained on opioid use disorder screening and provided OEND to veterans that are positive for opioid use disorder. This quality improvement study, supported by evidence from several studies focusing on the positive effect of OEND when accessible. And for the clinical implication, it is a continuous study, and I will continue with biannual training to all VA transitional housing. I will develop a policy and procedure to ensure that all new veterans in the program are aware of overdose prevention program. Also, I will set a quarterly reminders to providers for follow-up visits to alert them of the naloxone refill and conduct quarterly audits to for feedback to further refine this process or identify any other ways of improvement. Finally, this quality improvement project used a retrospective chart review design to establish a statistical increase in patients who screened for opioid use disorder and who had OEND training compared to no program. Prior to implementation of this study, like I mentioned, there were no overdose prevention program targeting homeless veterans in transitional housing facilities. Providing evidence-based intervention targeting population at risk such as the homeless veterans, is crucial in combating opioid crisis. Studies have demonstrated that OEND improve knowledge about opioid misuse and reduces opioid-related death. It is essential to have OEND accessible in all veterans in homeless population, and I believe that our or my organization will use this outcome to help safeguard practice. These are my references, and thank you so much for listening. I look forward to hearing a feedback. Thank you.